He was an examiner. Obviously, his knowledge is enormous. So obviously, he was not very generous with his marks. Anyway, so he was an internal examiner. The candidates didn't do well. The pass rate wasn't good. So obviously, after the exam, the candidates, when your internal examiner itself says the result is not good, they go and say, sir, this is a case of massacre, sir. And he keeps quiet. Normally, he doesn't respond. He gets up into his car. Sir, what do you think about it, sir? So many of us applied and so many failed. And he still keeps quiet. Then he switches on the car. Before the car starts, sir, you're not answering. Don't you think it's a massacre? He said, no, it's not a case of massacre, but a case of suicide, and he goes out. There are so many things like that. He was acting dean of Madras Medical College. Being the professor of surgery, he was acting dean. So, in our medical college days, we have a lot, the students have a lot of fun, lot of parties, and maybe Madras Medical College had a playing ground, and this function was held there. I think there was a little bit of liquor and all that. So I think there were small skirmishes. So the police wanted to come and take 1 or 2 of these medical students. Obviously, the rules. You need to ask the permission of the dean. So they come in and ask the dean, the police people, sir, we want to take in 1 or 2 for questioning. This man, why he asked, sir, no, they are drinking. So his response is, no, they are drinking on medical grounds. I can go on and on and on. Only one thing before I end, because there are so many anecdotes about him. He was about to retire, and his students wanted to, apply for extension because he was a teacher of repute. He didn't respond. Sir, please, sir, we want you to apply for extension. We will get it done and all. Finally, he said, I do not want to flex to extend. I hope you know what it means.
Apurva, I think Dr. Raman. Yes, let us start with it. Thank you, sir.
I'll go on for 1.5 hours with Professor Saranchand anecdotes.
We'll keep a separate lecture for this, sir. We did this thing. Hardik?
Yes, sir. Can I start, sir?
Yeah.
I think you should ask all the others to unmute because I think there is some disturbance.
Yes, sir. Rushabh, mute everybody except for the examination experts. Rushabh? Okay. Please mute everybody except, and we can unmute ourselves by pressing the bar key, so that's not an issue. Start. Hardik?
Yes, sir. I'm presenting the case on thyrotoxicosis. Myself, Hardik Kakadiya, under guidance of Pankaj Modi sir and Apurva sir and Vinit Chauhan sir. 62-year-old Hindu male patient residing at rural Mehsana, laborer by profession, belonging to lower socioeconomic class, present with in OPD, is complaint of weight loss 1.5 years ago, complaint of diarrhea 1.5 years ago, swelling in the neck since last 1.5 years. And patient is having also complaint of difficulty in closing eyelids while sleeping since last 1 year and redness in the eyes since last 1 year. Patient was asymptomatic before 1.5 years. Then he noticed a weight loss of 15 kg in 4 months associated with the watery diarrhea, 10 to 12 episodes per day for 1 week. Then he went to the physician and where he incidentally noticed the swelling over the right side of the neck and got medication after blood reports. And on regular follow-up, dose of the medications were increased. Swelling was initially smaller in size and gradually increased in the size, and then covering the both sides of the neck. Patient gained the weight and no weight loss since last 5 months. Patient is also having difficulty in closing eyelids while sleeping, which was progressively increased and associated with the redness in the eyes since last 1 year. He referred to civil hospital with same medications. Patient is having not associated with the pain or fever, no history of sudden change in the size of the swelling, no history of any other swelling in the neck, no complaint of the diarrhea, weight loss at present, no complaint of palpitation, breathlessness, and any vision problem. No complaint of excessive sweating or intolerance to heat or tremors or weakness. No any pressure symptoms. Past history. Patient is not a known case of diabetes or hypertension. No past history of tuberculosis or any other medical or surgical illness or blood transfusion. No history of any other medication or non-allergy. And patient is having no any significant family history. Personal history. Patient is a vegetarian by diet. Patient's bowel and bladder habits are unaltered at present. Sleep is normal. Appetite is normal. Patient is a chronic BD smoker and tobacco chewer since last 20 years. History summary. 62-year-old male patient presented with the complaint of weight loss 1.5 years ago associated with the watery diarrhea, which was 1.5 years ago, with incidental noticed neck swelling since last 1.5 years, which was gradually increasing the size and become current and also having difficulty in closing the eyelid.
Hardik, is somebody there with you on the mobile?
Yes, sir.
Somebody is interfering with your. Please switch off that mobile. Continue.
Patient is also having difficulty in closing the eyelids while sleeping with redness in the eyes since last 1 year. Patient got medication from private hospital after blood reports, and dose of the medications were increased 2 times in follow-up.
No. Can I stop you here?
Yes, sir.
Yeah.
Yes, sir.
When you started,
Go to the first
I'm not saying it might be the routine in your hospital, but why do you mention religion, Hindu patient or Muslim patient? Any particular reason? I just want to know. I'm not saying it's wrong, but I just want to know.
Actually, sir, some diseases are more in Muslim religions, and some are.
If you are really particular about that, if you are treating that disease, then you can mention. So you can ask the history, but when you are presenting, you don't need to necessarily tell that. But I will do whatever your examiners say for the exam. It's just my thought.
Yes, sir.
That is number one. Sorry, sir.
Yeah, sir. In the same line, this is what I told in the last class. Until and unless the religion has a connotation or importance in this disease,
exactly,
you unnecessarily cannot bring that thing.
Yes.
Please continue.
Then the next thing you mentioned about diarrhea. Now I know that you are dealing with toxicosis, so I'm asking you, when you mean diarrhea, is it just increased frequency or the consistency is really watery? Because I'm now biased because we know the diagnosis, we are discussing from behind. Normally, in thyrotoxicosis or hyperthyroid or whatever, you will have increased frequency. Of course, it may be loose, but it will not be like your diarrhea of GI system where that is really watery. So I'm not saying it's not watery here. I'm just asking you, how was the diarrhea? Was it frank, or were you referring to just the frequency? Because in thyrotoxicosis, yes, it will be a little bit loose, but it is the number of times which will be more rather than the consistency being really watery. When you mean watery diarrhea, you are giving me an idea whether it's like cholera diarrhea,
Hardik, sometimes patient will say that it may be unexplained diarrhea. Patient do not relate with their food habits or all these things. So you have to ask about that, right? Okay.
Yes, ma'am.
Then you mentioned anything about diet in the history? Did you mention
Diets?
dietary habits?
Yes, sir. Patient is a vegetarian by diet, sir.
Is a vegetarian by diet.
Yes, sir.
Okay. You said no history, no significant family history. What is the family history you will ask, or whatever you think of in such a case?
In family, if there is a same complaint, if there is in father or mother or in siblings, sir.
That is number one. See, you will generally ask history, I know, for all patients. But once you know a rough diagnosis, when you present to your examiners, you know you're dealing with a thyroid. So you will ask, is there any family history of thyroid disease? That's how you say, not similar complaints. Any family history of thyroid disease, any family history of goiter, something like that. You will not say similar complaints. You understand?
Yes.
You may ask them, but when you're presenting, see, when you present, you roughly have a working diagnosis. So when you present, you should present in such a way that they all correlate. Okay. I'm not saying it's you're wrong. I'm saying you should be better in that aspect. Sir, correct me if I'm wrong. This is my personal opinion.
Absolutely. No. Absolutely right, sir.
And the next question, you said he went to a private hospital, had medication. You should, if you know, you should mention what medication he had, because how is that important? According to your history, he has had medication and he became better, and subsequently he's not got any weight loss and all whatever. So you haven't told us. You might have asked him, but you haven't told us what medication he has taken, which has sort of relieved his symptoms to a certain extent.
Hardik, how much frequently patient was taking medication? Once in a day or frequently?
Madam, the patient had history and he was even giving the history of medication, but the patient is not a very well educated one. So just to inside this discussion, we have kept the name of the medicine away from the history part.
Okay, so that's a deliberate thing. Apologies.
Yes, sir.
Yes.
How much frequently patient was taking medication? That is also important.
Hardik, dose and a name.
Yes, sir. A patient is initially started on neomercazole 5 milligrams twice a day. Then after a month, he underwent a repeat thyroid function test, which was normal, and patient also gained the weight. But after that, after 3 months, he also lose the weight, and he went to physician and repeat the thyroid function test was done, which was suggestive of changes of hypothyroidism. And then he put on the neomercazole 10 milligrams thrice a day. After that, on repeat follow-up, also dose was increased up to 20 milligrams thrice a day. And at the time of presentation to us, he is already on 20 milligram neomercazole thrice a day.
Okay, that is also important. When patients say patient is taking 1 tablet in the morning, most of the time it is L-thyroxine is given. If patient is taking frequently initially, that is important, because if patient is on 5 milligram TID or 20 milligram OD dose, sometimes as a maintenance dose after 3 months. So patient may say this type of a history, and that is very much important when you take how much frequently patient is taking medicine, right? Okay.
You are mentioning your personal history that when you mean personal history, your bladder and bowel habits unaltered. I will not use it because he's been on treatment. The personal history is he had altered bowel habits. Okay, I'm not sure whether you can say, maybe you have added at present now.
Yet present, yes, sir.
At present.
Yes, sir.
But I wouldn't normally add it because that was his presenting complaint. He's taking medication. Okay. And his sleep has always been normal, or has he had any disturbed sleep before?
Generally, in thyrotoxicosis, sleep is.
No, I'm not asking about
Hardik, we are talking about this patient.
This
patient sleep is normal from the starting.
From the start.
Yes.
And his appetite has been normal from the start.
From the start, yes, sir.
Okay. Before you use the word addiction, you should know how many constitute addiction. I will say he smokes so many number of BDs and tobacco chewer, rather than use words like addiction, alcoholic. These are words which I will not recommend to be used. He consumes alcohol so many units per unit. Would be a better way. He smokes so many BDs a day for so many years. That is a better way of putting it than addiction.
Yes.
Sir, I hope my colleagues agree with me.
Yes, sir. Yes, sir. Perfectly fit. Sir, Raman, sir, your inputs?
Sir, on inputs, sir, that as sir has said, very, very relevant points. All of them are extremely relevant. The only thing to say is that at this present moment, the patient is under medication. Why has he come to you in a surgical clinic?
Patient came to us for a definitive treatment.
No, he was already getting.
So what is the presently complaint to you? Why did the patient come to you? Did he come for swelling or did he come for inability to close the eyes?
Yes. Patient came to us with complaint of neck swelling with difficulty in closing the eyelids while sleeping and redness in the eyes.
So that was a presenting complaint,
Yes, sir.
or did the private practitioner after putting the drug said you go to the hospital because you will require further management? That's what is asking.
Right. Because see, this is the reason about asking is that whenever you talk about a patient of a thyrotoxicosis, hyperthyroidism, the initial management of all the reasons will always be a medical management which will try to make the patient euthyroid. After the euthyroid status is done, there is a good number of patients who are not going to remain euthyroid and they are going to escape the medical management, or they are going to have a breakthrough along with other signs and symptoms about eye changes, as you have mentioned. So this is the reason the patient must be referred from that physician to your hospital, particularly for a surgical management of the thyroid disease. So please make the timeline of the history very clear. And in this one, you have mentioned about the diseases of the thyroid and the eyes, etc. Were there any diseases relating to the immune system in this patient? Any other diseases of an immune system?
Any other history
Let's
of
say rheumatoid
autoimmune
arthritis.
disorders? That's all
Patient
please
is
ask.
having
Autoimmune disorder.
no history of any other immune diseases.
Your answer
Okay.
to Professor Ramanuj's question, one of the reasons is timeline. He said you should tell him this should have been an answer. Sir, he's been on treatment for nearly 1.5 years, nearly 18 months. Still, some of his symptoms have become better, but he's not completely well. So he has been referred. That should be your answer.
Exactly.
Duration is a key point there.
Right. So that is exactly the reason. And the next point of this is that as you are mentioning about thyrotoxicosis, remember, did the patient have any history of fever and neck pain at the onset?
Sorry, sir.
Fever.
Was patient having fever or neck pain?
Fever. So
Fever or neck pain?
Pain. So pain is usually seen when there is a.
No, Hardik, listen to what he is asking. Did the patient have history of fever or pain?
No, sir. No history of fever or pain, sir.
Okay. Now, the next question, if that is it, what are the conditions in which there is a very painful thyroid enlargement along with a low-grade fever associated with the thyrotoxicosis?
Sir, subacute thyroiditis, sir.
Very good. So that means thyroiditis, etc., should always come. Remember that your patient to begin with is a male patient. The minute we talk about a male patient, we will be less thinking about a Graves and we will be thinking about other causes like a multinodular goiter. So as you are definitely, as I said, we are walking backwards on this case, this one. Number two is that, say this is a Graves condition. Remember, Graves is an autoimmune disorder. In your history, apart from the eye changes that you have mentioned, what are the other autoimmune things that you have asked in the history? We'll talk about, we are not talking of examination. We are talking on the history about other problems of autoimmune things.
To
begin with, was there any history of proximal myopathy or proximal muscle weakness?
Yes, sir.
Okay, what is the history that you took?
Sir, I asked about if the patient is having any weakness or not, sir.
Weakness in which part?
Sir, in
proximal myopathy,
proximal myopathy is there in the thighs or.
What is this?
How do you elicit the history, sir?
Proximal myopathy, sir, is very easily asked by asking the patient, can you comb your hair? Can you use a comb on your hair? Remember, the patient has to lift his hands to do that. Or if he's sitting on a chair, has he any difficulty in lifting him up? So these are the simple examples of proximal myopathies which are required to ask. Along with any skin changes, any finger or nail changes, any swelling of the legs. Okay, so these are all those things. Remember that Graves is an autoimmune disease. Beyond thyroid and eye, there are some other skin and nails and muscle problems. You have mentioned diarrhea, etc. So these are the things that you are required to say. Okay, right, sir, please. This is all on my end.
Thank you, sir. Madam, sir,
Hardik, what will be the skin changes in a patient having thyrotoxicosis?
Sir, ma'am, there is a pretibial myxedema.
What is it?
Is a deposition of the glycosaminoglycans in the dermis or the pretibial region, which will lead to semi-soft to hard, semi-soft to firm swelling over the pretibial region, which was pinkish or purplish on appearance.
It may be reddish or purplish patch, or there may be a generalized edema up to the knee joint. Right, so both the knee joint may be edematous from the foot to the knee joint. So patient may give that history, which is when you press it, it will be usually because of the mucin, and so it is not compressible. Right, initially it is compressible. Okay.
Hardik, what did you say was deposited in pretrivial? First of all, it's a misnomer.
Yes,
okay,
sir.
What is deposited? You said what is the substance they deposited?
Sorry, sir. What is?
You said some substance is deposited in the skin. What is the substance?
Sir, glycosaminoglycans.
What exactly? That's a very broad, it is
Sir, hyaluronic acid and
chondroitin sulfate.
Chondroitin sulfate
is deposited in the dermis.
Yes, sir.
Sometimes it can be pruritic.
Yes.
It is purplish, as madam said, or pinkish plaques, usually present in the
anterolateral aspect of the
yes. Usually no treatment is required, but I think this is something which we will discuss later on. But I just thought sometimes topical steroids may be necessary. This is all you have to know. And it is almost always associated with ophthalmopathy. You will never get pretrivial myxedema without ophthalmopathy as a general rule.
Hardik, you said patient is having loss of weight. What are the other causes for loss of weight other than thyrotoxicosis?
Malignancy.
Other than this, patient comes into the surgery department.
Malnutrition.
Okay, then. See, as you said, there may be anorexia nervosa, maybe tuberculosis, right? Sometimes urinary stone and urinary infection, recurrent urinary infection also give rise to loss of weight, right? So that should be kept in mind whenever patient says about loss of weight.
And right? Unrecognized diabetes mellitus, severe diabetes mellitus, all loss of weight, diabetes mellitus, thyrotoxicosis, tuberculosis, these are all you should bear in mind. Whichever patient it is.
Okay. Next slide.
Next, I think, yeah. Please proceed with the examination, Hardik.
Yes, sir. After taking informed consent, I have examined my patient in adequate light and exposure. Patient is conscious, oriented, to time present person and cooperative. Patient is having average build and average nourished. Basal metabolic rate is 23. Patient's weight is 59, height is 160 centimeter. Temperature of the patient is normal. Pulse is 80 beats per minute with regular rhythm and normal volume in the right radial artery. Sleeping pulse is 74 beats per minute with regular rhythm and normal volume in right radial artery. Blood pressure is 140 by 90 millimeter of mercury in right brachial artery in sitting position. Tremors are not present. Patient is having no pallor, icterus, cyanosis, edema, clubbing, or lymphadenopathy.
What are the type of tremors you will see for in general examination?
Fine tremors can be seen in the thyrotoxicosis.
Okay.
What is the differential? Sorry, ma'am.
Pardon?
Sorry, ma'am. Continue, ma'am. Sorry.
Sir, you ask because it was not.
You mentioned fine tremors. Whenever you see fine tremors, what is your differential diagnosis of fine tremors?
in Parkinsonism, there is a coarse pin rolling.
No. Sorry, once again, in an exam, when an examiner asks you, what did you have for breakfast? You should not say, I had what you had for dinner. I asked you, what is the differential diagnosis for fine tremors? You should not say, in Parkinsonism, there are coarse tremors. Did I ask you examples of coarse tremors? You should say coarse tremors. What are they? When you make fine tremor, one is okay, thyrotoxicosis. Is there any other example of fine tremor?
Anxiety.
Exactly, anxiety. That's all. See, in the exam, it's not just having knowledge. It is satisfying the examiner by answering to the questions which he is asking. This is a typical example. Ask about fine tremor, you should not tell about coarse tremor. The examiner examines many candidates. At some point in time, he will get bored, a little bit irritable. You should not add fuel to the fire, then you will only be the casualty.
Sir,
Okay.
they are human beings.
Exactly. That's what I'm trying to say. Yeah. So our aim is in the exam is not to demonstrate our knowledge. Our aim in the exam is to pass the exam. That's all. Sorry, I'll have to give you this, what shall I say, brutally frank feedback. That is the purpose of this.
This is
Yes.
what every day I tell to my residents, every day.
Please, yes, sir, we try to tell them that please listen to what the examiner is saying rather than giving answers. Please listen to what they are saying, what they are asking.
And normally the examiner starts asking questions from what you have and where you stop, because he doesn't have, most of them don't have preset questions. Now, since you talked about gross tremor, tell me what are the examples of coarse tremor. That is why you should know. We have to keep quiet, only answer the question. What is coarse tremor? Give me examples of coarse tremor then.
And then the Viva goes on to Parkinson's disease.
Yes, I'm going to ask now. I'll ask difference between Parkinsonism and post-encephalitic Parkinsonism now.
Sir,
Okay,
this is what is known as पैर पे कुल्हाड़ी मार दी या कुल्हाड़ी पे पैर मार दिया.
Anyway, just give me examples of coarse tremor.
Yeah,
don't worry, I won't ask
to.
details about Parkinsonism. Don't worry.
Hardik, answer.
Yeah, one is
Okay, you said Parkinsonism. Give me one more example. Cerebellar disease can cause tremor. Cerebellar disease.
cerebral disease, yes, sir.
What is the difference between tremor of cerebellar disease and Parkinsonism tremor? Very basic point, then we'll go off. We are not discussing medicine here. Apologies. Okay, we are wasting time. In cerebellar tremor, it is intention tremor. He will not have tremor, but if he is going to pick a pen from the table, then the tremor. Whereas in Parkinsonism, the tremor will always be there. It's typically called pin rolling tremor. Okay, let's carry on. See, this is the problem. You answer something unnecessarily, the examiner asks something unnecessarily. He's also feeling bored, no? He also wants to, break the monotony.
Sir, I would like to add something to that. This is very common problem with this generation. When you ask some question, they always give an explanation of answer rather than giving answer. A simple answer will suffice. They will say, why I am giving this answer. Let examiner ask second question. It will be a credit to you. So understand the question and answer only the question. Don't try to give explanation in detail.
Spot on.
Yeah.
Because examiner will decide whether he wants. He may be thinking of asking some other question. And after all, your explanation may be wrong after you give. Yes. Why unnecessary commit?
Okay, sir. Let us go back to thyroid, sir. That will be good. Okay, Hardik. Yes.
Yes, sir. Shall I continue with examination?
Please.
Yes.
Yes. There is a picture of the preoperative picture of the patient.
Can you zoom in on any one picture?
Yes, sir.
First of all, you don't need to tell pre-operative. Why give us the cat? Let the cat out of the bag. Just say this is the picture of the patient. See, because we are going backwards, we are already biased so much. we should act neutral, like umpires.
Yeah. The patient may not need surgery.
Yes. Tell me, what do you see there first?
Continue, Hardik.
Uh, on local examination, on inspection, I have examined the patient with proper light and exposure. There is approximately 15 by 10 centimeter butterfly slab, the diffuse swelling present in front of the neck. Horizontal extent of the swelling is from medial border of right sternocleidomastoid to medial border of the left sternocleidomastoid. Vertical extent is upper border of the thyroid cartilage to suprasternal notch. Surface is smooth, margin is well defined, inferior border is visible, overlying skin is normal, there is no scar or sinus over the swelling, swelling moves with deglutition, no dilated veins over the neck and chest wall, no other visible swelling in the neck. On ophthalmic examination, there is a patient is having infrequent leak with sterile loop, and conjunctival chemosis is present. On palpation, I will confirm my inspectory finding by palpation. There is approximately.
Can we stop at the inspection itself? Can you come back, please?
Yes, sir.
On inspection, what did you see in the eyes?
Sir, there is a.
Because you have not mentioned that. That's the inspectory finding, no?
Yes, sir. Redness in the eyes, and patient is having infrequent blink and white palpable fissure.
That's the only thing you found in the eyes? Go back to the picture, please.
Yes, sir.
That's what you. Is that the only thing you saw? Zoom the picture.
Yes, sir.
So what else do you see?
What else can you see? Is the inspectory finding?
Yes, sir. Patient is having a wide palpable fissure.
Yes. Then what else can you see? Can you see lid retraction?
Yes, sir.
Especially in the patient's left eye. Normally, do you see the upper sclera in a normal patient?
No, sir. Upper sclera is generally covered in normal patient.
In him, at least in the left eye, I can see the upper sclera is seen, which means what do you mean by it? There is some amount of lid
retraction, sir.
Why should you have lid retraction in all this thyrotoxicosis?
Due to sir, contraction of the levator barbaris superior muscle due to sympathetic activation.
Is it only the contraction of entire levator barbaris superioris? There is the autonomic component of the muscle. Only that, you understand, is not the entire. So, as you rightly said, there is a involuntary contraction of the autonomic component. So, the lid retracts. So, that is why you are able to see, especially in the patient's left eye, you are able to see the upper sclera. Okay. So, it is an inspectory finding. You have not told me that. Okay.
Yes.
Okay. Carry on. Next.
On palpation, approximately 15 by 10 centimeter.
One moment.
Yes, sir.
Okay, carry on.
Approximately 15 by 10 centimeter butterfly shape diffuse well-defined swelling with smooth surface in front of the neck. Temperature is normal. Swelling is non-tender. Consistency is soft to firm. Overlying skin is normal. On horizontal extent, it's from medial border of the right sternocleidomastoid to medial border of the left sternocleidomastoid. On vertical extent, patient upper border of the thyroid cartilage to suprasternal notch. Swelling is not fixed to the skin and not fixed to the underlying surface. Getting below the swelling is possible. There is no palpable thrill over the swelling.
Can I just interrupt you here? Sorry.
Yes, sir.
First of all, thrill is the palpatory finding. No thrill present. What is palpable thrill? Thrill itself is a palpatory finding. There is no such thing called palpable thrill. Thrill, when I say thrill present, which means I can palpate. So I will not use the word palpable thrill. Okay.
Hardik, cover padi thyrotoxicosis?
Yes, sir. Yes, sir.
Next
so
thing.
Thrill itself means palpable.
Yes, it's like saying auscultatory proving is seen. Do you tell that? You only say bruise. Similarly, you won't say palpable thrill. Thrill present. Thrill is a palpatory finding. Okay.
Yes.
You said you examine the patient. How did you examine the patient?
I have examined patient on a sitting position.
Yes. Sitting position. Then.
And from front, I have inspected the patient and
The position of the neck and the head.
Neck is slightly extended, sir.
First of all, we will not waste time. Any thyroid, you should, when you are palpating, you should palpate primarily from behind, but also come in the front.
Yes, sir.
So when you are palpating, you are palpating from behind is very important. That is something you should mention. I'm not saying you will not come forward and palpate, but palpate from behind and then in the front. That is very, very important. Then, of course, if you cannot feel any goiter, sometimes you will extend. But ideal position, according to me, is you should slightly flex slightly to relax the muscles. Only if you relax the muscles, you can feel the goiter nicely. Whereas when you extend, you're putting the muscles into contraction. Sometimes small goiters may not be palpable. I hope my colleagues agree with me on this point.
Yes.
Absolutely, sir.
Absolutely very, sir.
Yes.
Sir, absolutely.
This is what
I think
this is
what should
what we
have
do
been
in
the
the
first
clinics, sir. And I don't know why he's my resident. So this is how we
Absolutely.
examine. You are absolutely right, sir.
Hardik, how will you palpate if it is a small thyroid?
Yes.
Which method is applied?
To make it more prominent while flexing the head against, extending the head against the clasping hand over the occiput.
That is for the short neck. I am asking about small thyroid. Which is the method for that?
To make it.
What is Lahey's method? What
yes,
is Lahey's?
make it push the gland over the opposite side and palpate from that side.
Okay. What is Kreil's method?
Kreil's method is put the thumb over the swelling against the trachea and patient is asked to swallow.
In which patient will you use Kreil's method?
In nodular goiter, ma'am.
Okay, nodule or nodular.
Yes.
Nodule, particular. Okay.
Okay. Hardik, just a small thing to add to madam's comment. You see, whenever the examiner is asking you any size thyroid, small, large, medium, you always start by, I will start palpating the thyroid from the back with relaxation of the muscles. This is what sir said, and this is a very important point to demonstrate. Number one, if the gland is not well appreciated, the word is not well appreciated, particularly the surfaces for nodularity, then I will come in the front and do the Lahey's method, particularly for the medial lobes of the thyroid or posteromedial or lateral lobes. For solitary thyroid nodules, which are small, as madam's question is, that is the most relevant part, I will consider a Kreil's method by using the thumb rather than the rest of the two fingers for palpation. Okay, so this is the way to tell the examiner that I know the conventional from the back, then coming to the front for particularly nodularities in smaller thyroid. Okay, please continue.
Yes, sir.
To remember this, you have to remember like that CT. CT means Kreil's method, palpation with the thumb. And LP means Lahey's method, you are press and palpate. Right? Remember like that.
Very good. Please continue, Hardik.
Yes, sir.
Yeah, go ahead, Hardik. Krishna, sir, any inputs from your side?
No, just let him continue. We should not go on interrupting. That's right.
Yes, we should not go on interrupting. Yeah, please.
Okay, continue, Hardik.
Yes, sir. Bilateral carotid pulsations will palpable but spaced laterally. Trachea is centrally placed on auscultation. Bruit over the swelling is present. On cardiovascular system examination, S1 S2 is normal. There is no murmur. Patient is conscious and oriented. On bilateral air entry is present on respiratory examination. There is no any abdominal sound. Per abdomen is soft and non-tender.
Can I just ask you, when you meant bilateral carotid pulsation palpable but displaced laterally, what are you trying to tell us? What is the significance of your finding?
Carotid were present but displaced. There is a no invasion into the carotid sheath by the swelling. Sir.
So what are you trying to infer?
What is your conclusion?
Ruling out the malignancy, sir.
So what is that sign which you mentioned? Yeah, in a malignant goiter, if there is carotid infiltration, the carotid pulsations may not be palpable on that affected site. This is called Berry site. In benign, in so-called large benign tumors, it may be displaced. It is felt, but displaced laterally, which means it's a larger thyroid swelling. This is how you have to say. I know that you know, but examiner should know that you know. Okay. You mentioned about the swelling moving with deglutition. I know everybody would ask you, why does the thyroid move with deglutition?
Thyroid is encapsulated by pretracheal fascia, which were condensed posteriorly as a Berry's ligament, which was attached to the cricoid cartilage and inferior constrictor muscles. So during the swallowing, there is a upward and downward movement of the cricoid with inferior constriction that will lead to the upward and downward movement of the thyroid gland.
Yes, you are reasonably right. The thyroid is enclosed in the pretracheal fascia. I will say same thing. I will give us 3 reasons. The thyroid is enclosed in the pretracheal fascia, and the pretracheal fascia is attached to the cricoid cartilage and the oblique line of the thyroid cartilage. So if all the substances which are enclosed in the pretracheal fascia will move. The second reason, of course, is the posteromedial condensation of pretracheal fascia is called Berry's ligament. The Berry's ligament connects the posteromedial aspect of the thyroid to the cricoid cartilage. So when the cricoid moves, the Berry's ligament also moves. Third, the isthmus of the thyroid is closely related to the tracheal rings. Okay, so imagine when you swallow the tracheal rings move, so the isthmus which is attached to or which is in close proximity moves. So that is how you move. So in the same context, any substance or any structure within the pretracheal fascia will move. So give me some differential diagnosis of swelling moving with deglutition.
Subhyoid bursitis or pretracheal and prelaryngeal lymph nodes and thyroglossal cysts.
And thyroid swelling.
Yes, sir, and thyroid swelling.
Carry on.
Yes, sir. Case summary. The 62-year-old male patient presented with the complaint of weight loss 1.5 years ago associated with the watery diarrhea 1.5 years ago with incidental noticed neck swelling since last 1.5 years, which was gradually increased and become the current size, and also having difficulty in closing the eyelids while sleeping with redness in the eyes since last 1 year. Patient got medication from private hospital after blood reports, and medication dose of the medication was increased 2 times in follow-up. On examination, there is a approximately 15 by 10 centimeter well-defined butterfly-shaped diffuse with smooth surface swelling, soft to firm in consistency in front of the neck. It was moves upward with the deglutition and associated with the eye cells.
I will not say moves upwards, moves with deglutition. So it only moves up, doesn't come down, is it? So moves with deglutition. Carry on, please.
Yes, sir. As patient is my provisional diagnosis is primary thyrotoxicosis, the Graves' disease, and other is reference diagnosis is secondary thyrotoxicosis.
What is in favor of secondary thyrotoxicosis? Why do you want to keep secondary thyrotoxicosis?
Because, ma'am, patient is having older age, and patient having features of hyperthyroidism, and to rule out the multinodular goiter.
Okay. Now you're digging your own grave. You're very nicely diagnosed thyrotoxicosis. Okay. You're giving by telling primary thyrotoxicosis and secondary thyrotoxicosis. You're giving such a superb history. Now I'm going to ask you, tell me the difference between primary thyrotoxicosis and secondary. And then you will know, tell me.
Yes, sir. Primary thyrotoxicosis is generally found in the younger age, and there is a diffuse involvement of the gland. Gland is generally soft and diffusely enlarged.
Can I just interrupt? These are all other things. Cardinal point to say primary and secondary.
First and swelling maybe parallel or maybe later, sir.
See, in your history, you very beautifully pointed out that the swelling and the symptoms came together. Primary thyrotoxicosis means toxicity comes very positive, that is more or less at the same time with the goiter. Secondary thyrotoxicosis means in a long-standing goiter, toxicity supervenes. So these are diametrically opposite. You gave a very, very classical history about of how primary thyrotoxicosis occurs. Of course, there are other things are there. Primary thyrotoxicosis occurs in a younger age group. That is in an older age group. Primary thyrotoxicosis, eye signs are there. Typical. Secondary, you won't have eye signs. You are giving all typical things of primary thyrotoxicosis. Primary, you will have a diffuse enlargement. Secondary, it is nodular. Primary, you won't have less of cardiovascular. Secondary, more of cardiovascular. Then primary is more autoimmune. Secondary, unlikely. You give characteristic primary thyrotoxicosis. So you should say it's probably a case of thyrotoxicosis, most likely primary. That is how I will say. My colleagues can correct me.
Right.
Yes, only
So
age is against it, right? So you should say that because of the age, I have kept the secondary thyrotoxicosis. That suffice, right? Okay.
So the point is, Hardik, what I feel is that if you have a single diagnosis, you can always put in a single diagnosis. It is not that you need a differential diagnosis every time. As Madam has already said that you may put in that because the age is 62, I might put in secondary, but again, most of the features except for the age go in favor of toxicosis, primary. Urmila, would you like to jump in?
Hello.
Urmila? Yes, Ramon, sir.
Hardik, see, when I am making a diagnosis, if the clinical features of Graves are very clear, and as Sir has very, very importantly said, this primary, secondary things come second. First is the diagnosis is a patient with thyrotoxicosis or hyperthyroidism, whatever you call that. And I will now, this is the first line that you say to the examiner. Number two, due to primary, if the clinical signs and symptoms are very clear, as in your case, or secondary, as again Sir has said, goiter first with a big gap, then toxicity predominates, is a secondary. But if there are doubts about your diagnosis, like you are not very clear, then you can talk about, I want to discuss the differential diagnosis. Or if the examiner asks you very pinpoint, I am not interested, tell me the name of the disease, then your answer should be primary thyrotoxicosis. As you have mentioned, Graves' disease very bluntly. Remember that examiner is then going to ask you more details about why did you think this is Graves? What are the triad of Graves? What are the other autoimmune symptoms in Graves? These things are going to come up, which in your case is not that strong. So it is better that you tell the examiner, sir, primary it is thyrotoxicosis, probably primary. In the primary, I may have a few differential diagnoses like Graves or a toxic nodular goiter to discuss about. But this is the way you start telling the diagnosis. Okay. So number one. Number two is that in that clinical methods, remember you told about the swelling lower border. Just a small point, not very relevant in this case. Some examiners will like to ask about retrosternal extension of the goiter. Particularly remember a thyroid patient, not in this case, this is not that great goiter. But larger goiter sizes where the lower border is not well seen, surgeons particularly will like to ask because they are operating, they don't need surprises. So they want to ask you about retrosternal extension. So please get ready on those points. Apart from that, please continue, sir.
Before, just a quick question. There were one more terminology introduced. Hyperthyroidism. Now, Hardik,
Yes, sir.
the terms hyperthyroidism and thyrotoxicosis, do they mean the same? If
No,
so,
sir.
say yes. Otherwise, tell me what is hyperthyroidism, what is thyrotoxicosis?
Sir, hyperthyroidism is an overactive gland, sir. And thyrotoxicosis is a clinical state which is due to the excess thyroid hormone in the circulation, sir.
Very well done. Hyperthyroidism means the thyroid is functioning in excess. There's an inappropriate, high elevated secretion, synthesis and secretion. So that is one cause of thyrotoxicosis. But thyrotoxicosis means this is the body or a tissue is exposed to inappropriate high levels of thyroid hormones. It can be hyperthyroidism, it can be a transient phenomena of thyroiditis, or people can taking thyroid therapy can have excess time. Very well answered. This is something because you should never make mistakes in basics. Very good. Carry on.
Exactly.
Oh,
Urmi ma'am, are you there?
Sorry, sir.
That's all. How will you investigate this patient?
Yeah.
First of all, I want to do basic investigation, blood reports, and CBC, RFT, LFT, and INR with thyroid function test. And
Hardik, sorry to interrupt you on this point. Now, every test has a reason of doing.
yes, sir.
Please do not say as a postgraduate, I like to do some basic tests and then mumble out RFT, LFT, CBC. You don't do like that. You are a consultant who is going to be a consultant. Every test that you do should have a reason for that. Remember, the examiner is asking you, how will you like to approach? All these tests that are written by consultants are not done without a reason. So please be logical. Why did you like to do a complete blood count? And then please don't justify that, okay, sir, anemia will be seen. Hence, I have done that. That is not the main issue, sir. First is whenever you are giving a diagnosis, you need to confirm your diagnosis. How do you know that this patient has a thyrotoxicosis or a hyperthyroidism? Is the first question that you have in mind. Then your other investigations are supportive to your diagnosis. So please again reboot. Come to this one. How will you like to plan your investigations to confirm your diagnosis?
After basic investigation, I would like to do a thyroid function test first of all.
First of all, leave basic investigation. Don't even utter the word now.
Thyroid function
diagnosis,
test.
what will you do?
So thyroid function test first, sir.
But I'm an idiot. I can't understand thyroid function test.
Sir,
What thyroid function test will you do?
Yes, sir. Level of the sir, TSH, T3 and T4 in the blood, sir.
Once again, what would be your preference?
TSH is first, my preference, sir.
No, yes. When I meant you're right, you will do a TSH. But when you're doing a thyroid function test, would your preference be a total or a free? That is what I'm trying to ask you.
Sir, I would like to do sir free T3 and T4, sir, because it's the active part of the hormone which take part in the activity in the body, sir.
Because when you do a total, I'm not saying total is not accurate. A large proportion may be bound to the plasma proteins like albumin, globulin, and transthyretin. So when any condition which alters the plasma proteins may not give an accurate value. Whereas when you do a free T3, T4, it indicates the circulating level, and that is what is going to give you demonstrate in the form of your clinical activity. This is more so when you are thinking in terms of pregnant ladies, or when you are thinking in terms of people having liver problems, or sometimes renal problems, when the protein levels may be a little bit abnormal. So as a matter of fact, I would say doing a free T3, T4 TSH would be advantageous than overdoing a total T3, T4. Okay?
Yes, sir.
Yes.
So do you
Okay,
understand? Do you understand what
Hardik.
source is? In
Yes,
a
yes,
patient
ma'am.
having liver disease and pregnancy, there may be a normal TSH, right? And normal T3, T4. But if you see free T3 and free T4, it is raised, then you should think about it. Right?
Yes.
Okay.
Hardik, stop sharing the screen. We can discuss just like that now. Remember, you have anything? Okay. Any other investigations? Stop sharing the screen.
Yes, sir.
Just want to highlight that in pregnancy, generally TSH is low in second trimester, and for that we have to do free T4, and free T4 is normal, then the condition is due to pregnancy only.
Right.
Right.
What other
Yes.
investigation
Hardik.
will you do? I want to ask what other investigation will you do in a case of Graves' disease to diagnose Graves' disease?
After thyroid function, I would like to do ultrasonography of the neck.
Okay.
Uh,
Any other blood investigation to prove that this patient is having Graves' disease?
Antibody testing.
Which antibody?
More specific is thyroid stimulating antibody and TSH receptor testing, and we can do also anti microsomal antibody with anti-thyroglobulin antibody.
If antimicrosomal antibody positive, then
Its sensitive is less. I cannot rule out the Graves' disease, ma'am, because
but that can be a part of Thyrotoxicosis, the thyrotoxicosis, but in that goiter will not be present.
yes,
Hardik, just to recapitulate, can you hear me?
yes, sir.
Yeah.
Yes, sir.
If you want to do a antibody test to diagnose Graves, the answer, as you said, is a TSH receptor antibody, otherwise called thyrotropin receptor antibody. It's called TRAP as a short form. That has got 95 to 98% sensitivity, because your thyroid peroxidase antibodies will only indicate autoimmune etiology. It can be Hashimoto, like Madam said, it can be Hashimoto's thyroiditis. It just indicates autoimmune. It doesn't mean Graves' disease. Whereas if your TRAP is positive, 95 to 98%, you can be sure it is Graves. How else it is useful? Sometimes you may not see a swelling of the thyroid, but you may have eye signs. So if you have a TRAP which is positive, then it is Graves' disease. As Madam rightly pointed out, in a pregnant woman who has got a past history of Graves or who has got present Graves, you want to know whether the child is going to develop neonatal thyrotoxicosis. You will do a TRAP in the pregnant, because if the TRAP is high in the mother, that means it can go via the placenta to the children, and it can cause neonatal thyrotoxicosis. So you remember, the antibody which is specific for Graves is a TSH receptor antibody. Okay.
Yes, sir.
And any other investigation will you like to do to rule out that whether it is a Thyrotoxicosis or a thyrotoxicosis, or a subacute thyroiditis having a thyrotoxic phase?
Any scanning, any imaging technique to differentiate these three?
Iodine scan, radioactive iodine scan.
So how do you interpret it? What happens in toxicosis and what happens in RC and the subacute?
There is no uptake in hacetoxicosis in iodine scan, and there is a iodine uptake present in the primary thyrotoxicosis.
Sorry, you are saying it correct, but you should put it in such a way that the examiners don't ask questions. First of all, after the blood test, imaging wise, whenever the TSH is low, The first thing you will do is a nuclear scan of the thyroid, because we don't want to waste time. The nuclear scan of the thyroid can be, as you rightly pointed out, iodine 123 scan or a technetium scan. The iodine 123 is nowadays not commonly done because it is difficult to generate iodine 123, and moreover, you have to take images for 24 hours. So the commonly done scan is a technetium scan, which can be done within 2 hours. Now, when you do any of this nuclear scan of the thyroid, you want to differentiate. See, when you do a biochemical analysis, you are going to have a T4 side, T3 side, TSH is low. So all you know is the patient is toxic. You want to know whether it's hyperthyroidism, what is the cause for the toxicity. That is why you do a nuclear scan. In thyroiditis, there will be no uptake, as you rightly suggested. Whereas in hyperthyroidism, there will be an increased uptake. It is not only an increased uptake, depending upon the pattern of distribution, you will know if there is a diffuse homogeneous uptake, it is more likely to be a Graves' disease of primary thyrotoxicosis. If there is an increased uptake, but a heterogeneous appearance, there is increased uptake throughout, but it's not uniform, it is heterogeneous, then is more likely to be a toxic multinodular goiter. If there is an increased uptake in one spot and a suppression of the remainder of the gland, then is more likely to be toxic adenoma. So much of detail you can get by doing a nuclear scan of the thyroid. Hardik, have you understood?
Sorry, sir.
Have you understood?
Have you understood?
Yes, sir. Yes, sir.
You say yes, sir.
See,
After some complete.
the idea is what everybody is telling you. See, you are for all the residents. You may know things, but you need to explain in the way that the examiner understands that. Your answer may be correct, but if it doesn't comply with what he understands, then you are at loss. He doesn't have to give you a reason to fail you. You have to understand. So,
Apur, you are muted.
hello.
Yes,
Now you are audible. Okay.
Raman sir, anything from your side?
No, sir, I think till now the approach has been brilliant with TSH and the scan. Now, Hardik, just one question. You have done a scan and it shows a diffuse uptake on both the lobes, including a visualization of the pyramidal lobe. Beyond this, your nuclear medicine guide is that this is probably a case of a diffuse toxic goiter. You cannot comment on it, please. Now, will you like to do an FNAC from the thyroid?
Actually, sir, your voice is a breakdown.
What sir is asking you
Am I audible now?
Is audible now.
Yes,
please.
yes, sir. You are audible, sir.
Will you like to do an FNAC? The scan showed diffuse toxic goiter.
No, sir. No, I cannot do, sir, FNS in the diffuse toxic goiter.
So, no, sir.
Why,
See,
sir?
would you like to do an FNSC? Sir,
No.
Listen to what he is asking.
No, sir. No.
Okay, I will put it the other way. When would you like to do an FNSC if at all required?
If whenever I have doubt in my diagnosis, then
How will you doubt?
Okay.
How will you have a doubt in a diagnosis?
in this patient, there is a features of hyperthyroidism, eye signs were present, and the USG also suggested there is a diffuse enlargement.
You didn't tell me you did an ultrasound scan. That is my question.
Yes, sir.
Normally, I will do a nuclear scan, but I will also do an ultrasound. Why I will do an ultrasound? Number one, it will confirm the diffuse enlargement. Number two, a color Doppler will show you increased vascularity. Number three, it will also pick up suspicious nodules, because a toxic goiter maybe around 5% may be coexistent with malignancy. See, it doesn't mean everybody should have only one pathological diagnosis. Okay. So when I do an ultrasound, if there's any suspicious nodule, then I'll contemplate. But even before doing an FNAC, I'll make sure that nodule is not very vascular, take precautions and only do. I hope my colleagues agree with me.
Absolutely, sir. We also do the same. Particularly if your scan shows evidence of cold nodules and a few nodules which are not taking up, ultrasound is always a complementary investigation that must be done along with the scan. Absolutely, sir.
One more thing.
Absolutely.
I think we can clear out. Is it FNAC is not contraindicated?
Ultrasound should be done before scan. Ultrasound should be done before thyroid scan.
So if you want to do an FNAC in a toxic patient, you just see to it that the patient is under good control. That is what is more important, right?
But beware, some of the examiners will say, I will not do FNAC in a toxic goiter. So judge the mood of the examiner. Suppose he say, will you do it? In a very perplexed mode, then you back off and say, you back off, because many people will not agree, because the traditional teaching is FNAC is contraindicated in a toxic goiter. That's olden days. Nowadays, if you have an ultrasound and if there's a suspicious nodule, there's nothing wrong in doing an FNAC.
Sir has told you that it is a suspicious nodule. When will you say it is a suspicious nodule in ultrasonography?
When there is a echogenicity of the nodule, I want to check the echogenicity of the nodule on the ultrasound, and vascularity, and is there any calcific foci present or not? From that, we can judge.
Okay,
Urvi,
Hardik,
will you explain about it? Urvi, madam. Madam, you are unmuted. Okay.
Sorry?
Will you explain more about this?
Radiology in thyroid.
Thyroid staging. That's what madam is asking you.
Yes.
Thyroid.
In thyroid staging.
Thyroid staging.
Yes, sir. Yes, sir. In a stage thyroid 1, there is a benign component, and
no, Hardik, see, whenever someone is asking you the thyroids, always do not start with what is thyroids 1 and what is thyroids 5. Always start with there are 5 components in thyroids. This is what you are asked to start with. Number 2, based on the 5 components, the scoring is done. Based on the score, you make it TR1 0 and a thyroids 5 7 or above. Okay, so this is how we go around in the story. What are the 5 things that are seen in thyroids?
So one is echogenicity, one is vascularity, and micro or macro calcification.
No.
Please elaborate.
Hardik, the rule is very simple. It is CE2SM. C means composition, E is echogenicity, another E is echogenic foci. That includes microcalcification. S is shape and M is margin. CE2SM. CE2SM. E is echogenicity, anechoic, hypo or hyperechoic. Another E is echogenic foci. Remember punctate calcifications, microcalcifications, etc. S is shape, wider and tall or tall or wide. And M is margin. You club all of them, make up points. TR1 is 0, TR5 is 7 or above. Okay, yes. So this is how we examine that, right? I think, but in this case, we are not talking malignancies. We are talking how you assess that on an ultrasound. And as Professor Vittal has said, the reason you do an ultrasound is also you confirm with the Doppler. You see the echogenicity of the nodule, you see the nodule characteristics, see the Doppler, and see the other lobes as well. Okay, so ultrasound is a complementary investigation. Please note to say this during an examination. And if the ultrasound shows you some nodule more than one with a TIRAD 3 or TIRAD 4 or TIRAD 5, you should think about doing an FNAC if the patient is euthyroid. So this is the main takeoff. Okay.
Yes.
I think it is, now we can go to the management. So after you have done the investigation, it comes out to be a diffuse toxic goiter. Now, what is your plan? Because it is, what is your plan now?
Sir, if I would like to do, sir, thyroidectomy if patient is giving consent about the thyroidectomy.
Hardik, see, we are, as a surgeon, what you say may or may not be correct. But at 62 years of age, what will be the best thing for the patient?
If we are seeing the age, sir, there is a radioactive iodine therapy we should consider, but the size of the gland is larger, and there may be a chance of recurrence even after the radioactive iodine therapy.
That means you are not having clear ideas. Okay. First of all, you have given anti-thyroid drugs for nearly 15 to 18 months, if I remember right. Okay. So what anti-thyroid drugs was the patient taking? Let's start one by one.
Carbimazole, methimazole, or propylthiouracil.
What was this
patient was taking? Your
patient was taking carbimazole in 20 milligram thrice a day.
Normally, for how long will you give anti-thyroid drugs? Maximum duration, at
12
least
to 18
for
months.
classical teaching.
12 to 18 months.
What is the rationale behind 12 to 18 months?
We are if there is any remission occur after 12 to, there is some chances of remission after 12 to 18 months. Considering this point, we can give the anti-thyroid drugs.
Yeah, because this is an autoimmune disorder, there's a chance of remission. So you want to make sure the patient is euthyroid and hope for the immune activity to tide over. So you give for a maximum period of 12 to 18 months. Why can't you continue long term with anti-thyroid drugs? What are the problems?
Anti-thyroid drugs have many adverse effects, sir.
No, tell me what are the problems?
Sir, if you are using carbimazole, then there is a chance of granulocytopenia or agranulocytosis, sir.
What is it known as? What is it known as?
Sorry,
granulocytopenia. What is it known as? Idiosyncrasy to the drug. It is known as a idiosyncrasy to the drug.
Yes.
And when you stop that drug, a patient gives the history of recurrent sore throat, you get the investigations, and you stop the drug, patient will recover completely. So it is known as a idiosyncrasy. Okay.
So one is agranulocytosis, you said. What else?
Sir, there is of vasculitis, neuritis, skin rashes, fever, and
Okay. More importantly,
hepatic failure.
No, acute pancreatitis. You should keep in mind, it can give rise to acute pancreatitis.
And you said something about hepatic. What exactly happens?
Sir, if you are using propylthiouracil, it will lead to initially hepatitis, and then it will lead to ultimate fulminant hepatic failures. What
about carbimazole? Does it cause hepatic problems?
Yes, sir.
What type of problem does it cause? Okay, we will not waste time. Both are probably hepatotoxic. Your PTU is more dangerous, as you rightly pointed out. It can cause acute fulminant hepatic necrosis. Whereas when you take your carbimazole, the hepatic problems are mainly polystatic in nature. That is why carbimazole is a preferred drug to PTU, because potency-wise, carbimazole is better. Adverse effects-wise, carbimazole is better. Having said that, when will you use PTU?
Sir, PTU is actually a preserved drug for thyroid storm and in pregnancy, sir.
Why?
Because, sir, it have a high protein bound capacity, so it not transferred to the baby via placenta, sir.
So what happens to carbimazole?
is a decrease, low potential for protein binding in the circulation. It
Okay, let it
lead
go
to
to the
neonatal
baby.
hypothyroidism.
Sorry?
It lead to a carbimazole have a potential to do congenital disease in the baby.
What congenital disease?
Aplasia cutis or aplastic anemia. And,
Thyroid
Aplasia
related.
cutis.
What is thyroid related disease?
hypothyroidism.
Yes, patient may have thyroid swelling and hyperthyroidism, which will disturb. Patient will have because of the neck flexion is not possible. There will be difficulty in labor, right? So that is also important. Okay.
The two diseases are aplasia cutis in the newborn and esophageal atresia. So that is why carbimazole is not indicated in the first trimester. They will give PTU in the first trimester, and then our medical counterparts will change over to carbimazole in the second and third trimester. Remember that treatment of thyrotoxicosis or hyperthyroidism in pregnancy with regard to anti-thyroid drugs. If you are using anti-thyroid drugs, first trimester is PTU, second and third trimester is carbimazole. Radioiodine is a big no-no in all three trimesters. If you are contemplating surgery, you will do it only in the second trimester, not in the first or third trimester. So this is pregnancy and toxicosis for you. Okay?
Yes, sir.
Is the other
What is the
indication?
dose of it? Dose of propylthyroid.
Propylthyroid is 100 to 300 milligram per day.
So it is
Yes,
given
madam.
8 hourly, and that is important. 100 milligram 8 hourly. Okay.
What is the other indication of PTU other than pregnancy?
It's a result of for thyroid storm and
Okay.
thyroid storm.
Any other? When patient cannot tolerate carbimazole due to initial reaction, then we have to use PTU. Okay, go ahead.
Yes, ma'am.
So we have talked about anti-thyroid drugs. Okay, this patient has had anti-thyroid drugs for nearly 18 months. He's still got symptoms and has come to you. Now, definitive management, you have to, you mentioned radioiodine, you mentioned surgical intervention. Why did you choose surgical intervention for this patient?
Is patient is having large goiter over the in front of the neck, sir.
Okay, good.
And,
Good.
If we are doing radioactive iodine therapy, there may be chances of recurrence after therapy is more other than the surgery, sir.
Why chances of recurrence is more?
Inadequate therapy, ma'am, or
Dose required for radioactive iodine is more. That's why there is a chances of recurrence. And other way, if we ask that what are the indication of surgery in case of a thyrotoxicosis?
You gave one answer. Large goiter. Then next.
Compressive symptoms were present.
Okay.
And
then retrosternal goiter. Then when there is suspicious nodules. Okay, suspicious nodules. Then Graves' ophthalmopathy is a relative contraindication. When a patient has got, that is a reason you can say, when a patient has got eye signs, radioactive iodine is a relative contraindication, because on the presumption, when you give radioiodine, there may be flaring up of the eye symptoms. So Graves' ophthalmopathy is a relative contraindication. What else? If the patient wants to have a child in the next 6 months to 1 year, you don't want to give radioiodine. So these should be some of the indications. Large goiter, retrosternal goiter, suspicious nodule, as you said, pressure symptoms, Graves' ophthalmopathy, a patient wanting to conceive within the 6 months to 1 year will be some of the indications. Madam, correct me or you can add some points.
All are taken up, sir.
Okay.
Hardik sir?
In pregnancy,
No.
sir, right? Pregnancy, second trimester, we can go for surgery.
Right, sir. I think that yes, all the points have been discussed. And the only thing that goes technically against surgery or being offering surgery is patients who have such comorbidities where the risk is so high. That will be the only point where surgery may not be offered. But all the other things, yes, surgery is there. When you compare about radiotherapy, as Professor Vittal has said, the most important points about radioactive iodine is that when pregnancy is a strict no-no, and if you're thinking about a thyroid malignancy which you suspect, then you have to take that thing out. So these are the strict no-nos of a thyroid radioiodine. The rest of them are discussed on a case-by-case basis, and then you talk to your endocrine surgeon or your endocrinologist, and then you plan about what is to be done. I think, sir, very good discussion on that point. Please.
Yes,
Madam, can you, Madam, before we go for surgery, can you give some salient features regarding radioactive treatment?
yeah. Radioactive iodine is first there is a iodine scan is done to find out the exact dose for that patient, and followed by the capsules are given in that dose to the patient to swallow. And after that, for 3 days, he has to take care of his feces and urine, and proper this discharge is to be taken. Yeah, disposal is to be taken. And sometimes it happens that we have to follow the patient for a period of time to do the T3, T4 and TSH and know whether the patient is going into hypothyroidism or not. There is 99% chance of patient going in hypothyroidism after radioactive iodine therapy. So we have to tell the patient before going for radioactive iodine therapy that this will happen and the disease you have is not good, and the hypothyroidism is not having any complication like thyrotoxicosis.
So, madam, when do you start altroxin? See, in surgery, we start 3 to 7 days after surgery.
Yeah.
When do you start altroxin?
Have to measure thyroid function test repeatedly, and then when the TSH starts rising, then and then I will add altroxin. Because in some
what
patients,
is the duration? What is the duration?
Maybe 6 weeks to 6 months.
Okay, okay.
Sir,
yes, sir,
Sir, can I just answer?
Yes, sir. Yes, sir.
Whenever you give radioactive iodine ablation, first thing I want the students to know, most of them, whether you're doing radioactive iodine ablation or surgery, most of them should be made clinically euthyroid to decrease the chance of thyroid storm. Thyroid storm occurs usually when you do not make the patient euthyroid before submitting them to either surgery or radioactive iodine. So patient will need anti-thyroid drugs. Only caveat is when you're doing a radioiodine, you will stop the anti-thyroid drugs around at least 3 days before giving radioactive iodine. Otherwise, the anti-thyroid drugs will inhibit the uptake of iodine. So that is number one. So after giving radioactive iodine, again you will start the anti-thyroid drugs, because in surgery, you immediately cause hypothyroidism by removing the gland. So you don't need, you stop anti-thyroid drugs, you don't give anti-thyroid drugs after surgery. Whereas in radioactive iodine, it is a gradual process. So some of them may need anti-thyroid drugs for a few weeks. As Madam rightly pointed out, you will do regular tests, T3, T4, TSH, to find out the status of the thyroid and slowly decrease the level of thyroid hormones. And then at some point in time, after 3 months, you will find that you will require thyroid tablets. So point to be noted is, even for radioactive iodine ablation, you will give anti-thyroid drugs, However, the anti-thyroid drugs should be stopped 3 to 5 days before radioactive ablation. Most people will require post-ablative anti-thyroid drugs for a few weeks because in radioactive iodine ablation, it is a gradual hypothyroidism. It doesn't occur immediately, so the hyperthyroid status will be there for some time. However, in surgery, you will give the last dose on the day of surgery or before surgery. After surgery, you will not give anti-thyroid drugs. That is the message which I want to give you.
Right, sir. Right, sir.
Very nicely explained, sir. Good.
Now,
Doctor,
you did surgery for this patient. How will you make this? What are the prerequisites or pre-operative preparation you will make before doing surgery for this patient? What did you do in your patient?
Before surgery, I would like to make a patient euthyroid by continue anti-thyroid drugs with.
Around 3 months then.
Sorry, ma'am.
It will take 3 months to make a patient euthyroid. Then what will you do?
I can make a patient euthyroid by adding the beta blockers like propranolol and by using lugol iodine.
Propranolol?
Propranolol is prevent the peripheral conversion of the T4 to T3.
Dose.
Dose 20 to 40 milligram.
Oh,
22?
20 to 40 milligram.
Okay.
what,
So you have to go up to 80 milligrams sometimes to reduce the peripheral signs of the patient like tachycardia and tremor. And that is more important than to make a patient euthyroid.
So that symptoms will be relieved by propranolol and you have to give it BD, not OD. Right. Okay.
Yes,
your preference will be propranolol or any other beta blocker?
Mainly propranolol. If the patient is having asthma or cardiac failure, then I would like to
bronchial asthma, not asthma. Specify bronchial asthma.
Then I would like to use calcium channel blockers.
First of all, the question is, will you use propranolol or some other beta blocker?
Nadolol.
So,
Nadolol.
why nadolol?
It's a short-acting.
That is not a question. As you rightly pointed out, propranolol is a non-selective beta blocker. So if the patient has incipient bronchial or asthmatic disease that may precipitate, ideal thing would be a cardio-selective beta blocker like metoprolol, atenolol, or so many other cardio-selective ones. That would be your preference. Okay, that is what you should give. Of
Then
course,
why should you? Why are you starting propranolol? Hardik? As Sore said, it is a good drug. Metoprolol is a better drug than propranolol. So why are you starting propranolol?
Because
it is a cheaper drug. Yes, it is a cheaper drug and is easily available into the government hospital, right? So that it is started as a first drug.
Otherwise, now trials have been done that metoprolol is a little bit better than propranolol in case of preparation for surgery.
okay, so you put the patient on anti-thyroid drugs, very good. You put the patient on beta blockers of your choice. We'll accept your choice. Is there anything else you can do to make the patient euthyroid?
Lugol iodine.
What is Lugol iodine?
Lugol iodine is a combination of the iodine plus potassium iodide.
Yes. Then what is the difference between Lugol iodine and saturated sodium potassium iodide? Lugol, I won't waste time. Lugol iodine is, what is Lugol iodine? 5%?
5% iodine with 10%.
Yes. How much of Lugol iodine will you give?
3 drops BD for 7 to 10 days before the surgery.
Okay, how will you give Lugol iodine? Because iodine itself will take 1 hour for us now. How will you give Lugol iodine?
is Lugol's iodine is in diluted solution in the 100 ml distilled water.
Why? Why
Sir is
distilled water?
asking.
Why distilled water? You want it to be pure distilled water? Okay, I won't waste time. You cannot have those drops. They are so pungent. So you will mix it with milk or fruit juice. You will normally give 5 to 7 drops, 8 hourly. And you mention number of days. Why number of days? What is the sanctity behind that 7 or 10 days? Why?
Because
What is the role?
it will take time to prevent the release of the hormone from the gland.
Okay. Imagine, according to me, iodine is a raw material for thyroid hormones. Iodine will precipitate thyrotoxicosis. But you are telling me to give iodine. How will that tell me? I don't know. You're telling me the exact opposite now.
Or in a simple way, Hardik, you are asking about
creating the thyroid constipation by preventing its release.
Very good. Good.
Super,
So what happens?
super. Very good.
So if you give for
So what
more than
happened?
10 days, what will happen to the patient?
The patient, if you are giving 10, help to patient make euthyroid.
No, why you are not saying?
No, it
Okay,
is
my
not for
question is,
euthyroid.
give the iodine for 2 weeks, I'm saying. Will you give for 2 weeks? Okay, we will not waste time. You are right. Small dose of iodine will cause increased thyroid hormone synthesis. But in your Lugol's iodine or saturated solution of potassium iodide, you give a higher dose of iodine. When you give higher dose of iodine, it inhibits iodine uptake into the cells. It inhibits higher organification and thereby decreases thyroid hormone synthesis. It also inhibits release of the hormones. Because of this, there is decrease in the thyroid hormone. However, if you give for more than 10 days, this effect, there's an escape phenomena. So what happens? There will be increased synthesis. So you should give this only for 7 to 10 days. If you give for more than 10 days or 2 weeks, then there is a term called Wolff-Chaikoff effect. That means if you give high dose of iodine for a longer period of time, what happens?
It will lead to hyperthyroidism.
What is Wolff-Chaikoff effect is
Prevent
administration of iodine causing inhibition of thyroid organification is called Wolff-Chaikoff effect. But if you give it for more than 2 weeks, there's an escape phenomena. So on the contrary, you'll have more hormones. So that is why you will limit if whatever iodine you're giving, whether it's Lugol's iodine or saturated solution of potassium iodide, you should give it for 7 to 10 days. Madam,
Patient may go into thyroid storm if you give for more than 2 weeks.
sorry, ma'am.
Patient may go into thyroid storm.
If you
There
give
is
for a longer
escape
period.
of constipated thyroid hormones, and so because of it escapes from the gland which is already collected, so patient will develop thyroid storm. So what is the advantage of giving Lugol's iodine? Why do you want to give Lugol's iodine before surgery?
Increase the vascularity and
Right? And gland becomes firmer. So when you wants to do, previously we were ligating, we were not having good cautery and this bipolar and monopolar cautery. So we were ligating all the vessels. And so that will not allow it, it will get cut through. So firm gland will be there and there will be reduction in the vascularity, right? Okay.
so we have prepared the patient. You have done a marvelous job of making the patient euthyroid by giving anti-thyroid drugs, beta blockers. Patient's pulse rate is around 70, and you are given iodine for 7 to 10 days. So now you are going to do surgery. What surgery will you do? For toxic goiter.
Sir, one more thing before we go for this. What other things you would like to see before putting the patient for surgery?
What?
Any other investigation you would like to do before going for surgery?
Of course, you'll want to get a cardiac fitness. to make? Is there anything specific you're asking me, sir?
Sir, two things. One is serum calcium and one is vocal cord movements.
That is routine. I didn't, of course, you will want to do a vocal cord.
Just to complete the list.
I will not only do a serum calcium, I will also do a vitamin D. I will do pre-operatively serum calcium and a vitamin D.
And an ideal examination for vocal cord movements.
Yes, sir.
Okay, please continue, sir.
Which surgery will you do?
Near total or total thyroidectomy?
What is the difference between near total and total thyroid?
In total thyroidectomy, complete gland was removed. Gland is removed. In near total, only 1 to 2 gram gland is left.
Why total?
Sorry.
Why total thyroidectomy?
Because ma'am, if remaining tissue act as an antigenic stimuli for the antibody, sometimes it creates a problem. Sometimes it may continue the hyperthyroid state in the patient.
And which can be the immediate complication for total thyroidectomy?
Immediate complication of total thyroidectomy.
Hemorrhage.
So that is surgical complication. One. Anything else?
Medical
endocrinologist.
Hyperparathyroidism. Hypoparathyroidism.
Yeah. So what will you like to do in total thyroidectomy? Will you preserve one of the parathyroid gland?
Yes, ma'am. Yes, ma'am.
Yeah.
All, rather not one man. All. We will try to preserve all the
All the
parathyroid.
parathyroid glands.
Udana Kasta, something. Yes, sir.
And how will you treat it?
Yes, Vital sir, you are saying something.
No. I just wanted to ask, Madam rightly pointed out, one is hemorrhage, two is hypocalcemia. In toxic goiter, why should you have hypocalcemia? One, okay, there's a temporary hypocalcemia or permanent because you have done something wrong to the parathyroids. What else can be the reason? What happens in thyrotoxicosis? What happens? There is demineralization of the bone. Once you do a surgical correction, the calcium starts getting deposited back into the bone. Not only calcium, little bit of phosphorus also. In fact, when this becomes severe, this is called hungry bone syndrome. You will have a decreased calcium, sometimes decrease in the phosphate also. And that can be prolonged. So in addition to your parathyroid problem, when you're doing surgery for toxic goiter, remember there's an entity called hungry bone syndrome. This is not only seen in surgery for toxic goiter, this is also seen after surgical correction of primary hyperparathyroidism. That's a totally different thing altogether. But you should remember hungry bone syndrome. Madam, Dr. Uruvi, madam, you want to throw more light or agree with me, madam?
True, sir. Correct. Perfect.
So this is something you should remember.
Ramanu sir, any inputs on your side?
I think, sir, yes. Number one is that, as Professor Vistal has mentioned, two things that everyone has to remember: serum calcium and vitamin D before you plan the surgery, and as you have said, a vocal cord examination before. And number two is that a cardiac checkup is absolutely mandatory, and then we plan the surgery. I think, sir, we should now proceed to what surgery and what are the selections about subtotal, near total, and total, and what are the things that should be done in a grave or any toxic goiter.
Right, sir. Please.
Okay, Hardik, on this aspect, as we have been discussing about total and near total, in a patient with a grave, there has been a big thought about doing a subtotal thyroidectomy, particularly it was done before, we have shifted now to total. What are the advantages of doing a subtotal thyroidectomy on a patient with a Graves' disease? And what is a subtotal thyroidectomy? So there are two questions.
Yes, sir. In subtotal thyroidectomy, there is a 7 to 8 gram gland tissue of the gland is left behind. Advantage of the subtotal thyroidectomy is that patient is not underwent the complete hypothyroidism after the surgery, sir.
Okay, then please continue. And what are the other advantages?
Prevent the less occurrence of parathyroid.
Yes.
Very good.
The chances
So
of
less chance of damage to parathyroid is recurrent variant.
are said to be less. Okay, but they are still present. Remember that. But tell me one important point. See, if you have done a subtotal thyroidectomy and follow the patient for 10 years to 20 years, what is the ultimate fate of the thyroid gland in a patient with a Graves?
In Graves' disease, thyroid tissue is continuously act as an antigenic stimuli for antibodies.
No. So ultimately, at the end of 10 years to 20 years, does the patient remain euthyroid, hyper or hypo?
Sir, hypothyroidism.
Yes. So please remember that it is technically a burnt out phenomenon that produces a hypothyroidism. But there is more serious concern that remnant can act as a nidus for a malignancy. And if there is a recurrence in that stump of the thyroid, that will be very difficult for you to manage in the post-operative period after a subtotal. Okay. Say there is a recurrence from that stump of Graves' disease. Then what is the treatment that is planned?
Sir, radioactive iodine, sir.
So radioiodine ablation. Remember, the radioiodine ablation also comes with a bad side effect. The parathyroids that are by the side of the thyroid, they will also incur the radiation damage because of that also. So these are the points that we have said. Now, important things that is less discussed is, what is thyroid storm?
Thyroid storm is a severe hypothyroidism occur in a stressful situation and infection like sepsis and thyroid surgery during thyroid surgery or inadequate radioiodine therapy or in
So when question is asked, what is thyroid storm? So when thyroid storm is not the question.
Patient is
So what is thyroid storm? When will you say it is a thyroid storm?
Patient is having a severe intolerance to heat, perspiration, and palpitation.
That occurs even in thyrotoxicosis. How will you say it's a thyroid storm? Okay, it is an exaggerated signs and symptoms of thyrotoxicosis. Remember, it is an exaggerated signs and symptoms. You will have a fever more than 1 or 2 degrees Fahrenheit. When your cardiac symptoms are exaggerated, you may have AF, all those problems. Your CNS symptoms are exaggerated. Patient may have delirium, confusion. See, basically, thyrotoxicosis, thyroid storm is a decompensated thyrotoxicosis. You have thyrotoxicosis going on to multi-organ failure. Temperature more than 1 or 2, your cardiac, there's decompensation. CNS, you have GI symptoms. It is essentially a clinical diagnosis. There is no investigation. Your TFTs will not differentiate between thyrotoxicosis and thyroid storm. Why is it very important to recognize and prevent thyroid storm? Why?
So it's a fatal condition, sir, if we are not intervening.
Even once it occurs, in spite of your best treatments, the mortality rate is 10 to 20%. So your aim should be to prevent thyroid storm. Carry on, please, my colleagues.
And if thyroid storm happens, then how will you treat?
First of all, on infuse the saline and oxygen supplementation. Then using the anti-thyroid drugs first, like propylthiouracil in higher doses, and beta blocker. And if not controlled, then we can also use the steroids, ma'am.
Yeah, corticosteroid is the mainstay. Which corticosteroid in how much dose? I don't think so.
Hydrocortisone 300 milligram. We can give hydrocortisone 300 milligram straight. After that, 100 milligram 8 hourly.
8 hours.
You can give maximum 1000 hydrocortisone. You may require, some patient may require 1000 hydrocortisone. Straight you can give 200 or 300. Then every hourly patient may require hydrocortisone until temperature goes down.
Yeah.
Right.
Basically, remember, you should try to prevent it. How will you prevent it? By making the patient use thyroid prior to surgery or radioactive. In the modern setting, you should not see thyroid storm. If you see thyroid storm, it is our mistake. That is, in an unrecognized, suppose in an unrecognized thyrotoxicosis patient, if a patient has any trauma, sepsis, fair enough. But you should never get thyroid storm after radioactive iodine ablation or surgery because it is a preventable condition. The principles of treatment: one, inhibition of release. Like madam said, you give your PTU and you can also give high dose of carbimazole. Inhibition of release. Only thing, you will give a higher dose than normal thyrotoxicosis and more frequently. Two, inhibition of release. You can give iodine. Same iodine, you give a little bit higher dose and more frequently. Three, you also want to give steroids. Why? In any thyrotoxicosis, there is a relative adrenal insufficiency because there is increased degradation of cortisol. Therefore, there is adrenal insufficiency, more so in the case of thyroid storm. So you have to give steroids to correct this, and not only that, your steroids also convert your what? What does the steroids do? It inhibits the conversion of T4 to T3. Then supportive measures. You first started saying saline. You should not say supportive measures like IV fluids, cold sponges or compresses for your fever. You have fever more than 1 or 2. That is the way you have to tell me. Okay.
Sir, there was a question from the resident. Somebody has written a question that if the patient is clinically hypothyroid, do you need to do a thyroid profile before going for surgery?
I will say a patient should be clinically and biochemically euthyroid. However, when I mean biochemically euthyroid, T3 and T4 should be normal. I will not wait for the TSH to be normal because TSH normality will take at least 2 to 3 months. So once the patient is clinically euthyroid, that is, he has no tremors, his pulse rate is acceptable, and T3 and T4 is normal. If the TSH is a little bit low, I am happy. This is the practice. You don't need to wait for your TSH to be normal. But definitely biochemically, I will want the patient to be euthyroid.
Right, sir. Right, sir. Ramanu, sir? Dr. Ramanu?
Sir, you are muted. You are muted. Raman, sir, you are muted.
Raman, sir?
Right.
Unmute yourself.
Okay.
Yeah.
Right. Hardik, on this point, as this is a male patient, what are the pointers that will suggest that this patient can have a malignancy along with a patient with a thyrotoxicosis? Or what are the pointers that a patient with a thyroid nodule, now this is a general question, with or without hyperthyroidism has a malignancy, or when will you suspect a malignancy in a patient with a thyrotoxicosis?
if patient is having a solitary and cystic component of the nodule, both are present, and rapid increase in the size of the nodule.
Again, Hardik, see, the points are simple, like as you had discussed in a thyroid malignancy. Number one is that the history of a nodule or a size of a nodule increasing rapidly. It is fixed to the surrounding structure. A history of a recurrent laryngeal nerve palsy, cervical lymph nodes are important markers that could be in association with the thyrotoxicosis.
Yes.
Okay, so
Yes.
these are the good things, or more or less we have a good extensive discussion. An important point to understand is that, can you have a thyroiditis as a differential diagnosis? Thyroiditis as a differential diagnosis, or what kind of thyroiditis will come in this differential diagnosis?
So is this patient Hashimoto thyroiditis, sir?
Okay. What are the usual clinical features, or how does the natural history of a Hashimoto go by?
Is a autoimmune condition. Initially, there is features of hyperthyroidism, and later on, due to when there is a store of the hormone is decreased, then eventually it leads to the hypothyroidism due to destruction of the glands.
So I want to ask, what are the points against thyroiditis in this patient? For thyroiditis in this patient, what are the points against thyroiditis?
18 months you have been using anti-thyroid drugs. That itself is
See the history itself.
first most important point. You use the word in Hashimoto's, there will be hyperthyroidism. Don't use the word. There is no hyperthyroidism in Hashimoto's. I told you the difference between hyperthyroidism and thyrotoxicosis. What is the pathology in Hashimoto's thyroiditis? There is inflammation. So some of the follicular cells are destroyed. When the thyroid follicular cells are destroyed, they release their hormones. That is why the released hormones, there's a transient increase in the thyroid hormones. That is called acetotoxicosis. So it's a thyrotoxicosis, not hyperthyroidism. Hyperthyroidism means the gland is functioning in excess. In thyroiditis, the gland does not function in excess. It is destruction of the follicular cells, releasing the hormones already synthesized. So there's a transient phase of thyrotoxicosis. Then the patient becomes euthyroid, and in 80 to 90%, there is a phase of hypothyroidism. This is the natural progression of disease in a case of Hashimoto's thyroiditis. Okay? Here your points against it is,
Yes.
it won't be there for 18 months. It is usually there for 1 or 2 months, maximum 3 months. And you should have done a nuclear scan. For Hashimotoxicosis, you will not use anti-thyroid drugs because there is no increased synthesis. You will only use symptomatic treatment like beta blockers. The very fact that you use for nearly 1.5 years anti-thyroid drugs precludes Hashimoto's Hashimotoxicosis. Okay?
Yes, sir.
Clinically, generally,
Your patient requires 20 milligram of the carbimazole 8 hourly. It's a very high dose. So patient of Hashimoto's will not require that much carbimazole, right? Okay.
usually goiter and the eye signs are usually absent in thyroiditis. Am I right?
Right, ma'am. Absolutely, ma'am, I think.
So this patient is having both. So it's
Yes, yes,
out of-
yes, ma'am. Yes, ma'am. Yes, ma'am. Yes.
So
Anything more? Yes, sir.
No,
Yes, sir.
I think since it is Graves' disease, it is more just theoretical points. Hardik, can you tell me the possible etiology or the precipitating or risk factors or whatever for Graves' disease?
The precipitating factors are excessive iodine in postpartum period, or infection or
So infection causes is it?
also is a triggering factor for the Graves' disease.
Very good, triggering factor. Yes, then.
And
Okay, one is genetic causes. Some patients are predisposed, like HLA, DR2, DR3. I think my medical counterparts will know more than me. So patient can be genetically predisposed. Now, genetically predisposed, there are other predisposing factors. Number one, smoking. Smoking is associated with Graves' disease, especially Graves' ophthalmopathy. Number one. Two, as you rightly said, stress. Any emotional trauma like bereavement in a genetically predisposed patient can predispose. Three, what else?
Iodine, sir.
No, you said about yes. Generally it occurs in iodine sufficient areas. Okay, iodine does not directly cause, but in iodine sufficient areas, maybe. Therefore, as you rightly said, infection. There are certain viral infections or certain bacterial infection can cause as a trigger. Lastly, now there is some evidence that selenium deficiency can cause Graves' disease. That is why in some people give selenium supplements in mild Graves' disease. I think Dr. Urvi will be a better person than me. Madam, can you throw more light?
Sir, selenium deficiency is now indicated as a cause of thyrotoxicosis. But sir, stress is the major factor for as a trigger factor for thyrotoxicosis.
Yes. So I just wanted to be clear. Smoking. That is also Graves' disease and smoking. The way I will remember to make it easy, the triggering factors. Number one, stress. Yes. Number two, sepsis, infectious trigger. Number three, okay, whatever order. Selenium. Number four, what else did I tell you? Smoking. So remember these. These are some triggers. Okay. What is the pathogenesis or pathophysiology of eye disease of Graves? Tell me. Why should you get ophthalmos or whatever?
There is a antigenic sharing between the tissue, ophthalmic tissue, like a fibroblast and a muscle.
It's not sharing. Antigen antibody reaction. We now know that you've got a TSH receptor antibody that acts in the antigen in the extraocular region or retroorbital region. There's antigen antibody reaction. Yes, what happens because of that?
There is a cytokine mediated injury.
Yes.
Which will lead to the deposition of the hyaluronic acid or chondroitin sulfate, which lead to the ultimately they accept the water and swollen and ultimately become fibrous.
Yes, very good. So basically it secretes hydrophilic glycosaminoglycans. Hydrophilic means it absorbs water. So there is increase in the retrobulbar pressure. So the eyeballs come out. What muscles are usually involved in Graves?
Generally, inferior rectus and medial rectus were affected.
I may be wrong. I think it is superior rectus and inferior oblique. But kindly check up. Okay.
Yeah, sir, it's right. It is a superior oblique and inferior rectus. Right.
Okay. Good. I think we had an extensive discussion. I leave it to the host to decide whether we can call it a day.
Okay, Ramanu sir.
Sir, no other points. I think that it has been a very, very good discussion today.
Sir, can we throw some light on the eye signs? I know it's an extensive disease, extensive discussion. If you can just throw some light on because after all, thyroid, most of the time we tend to lag behind in the eye signs.
So generally, 20 to 30% of Graves' disease will have ophthalmopathy. Among ophthalmopathy, the commonest eye sign is lid retraction, because the upper lid is pulled up. As I told you today, excessive autonomic component of levator palpebrae superioris. Then you may get exophthalmos. Exophthalmos may be lid retraction is present in 90% of eye signs. Exophthalmos may be around anywhere between 60 to 70%. And you have different eye signs. Starry look is called Stelwak sign. Difficult in convergence is called Mobius sign. I mean, these are all named signs. Then absence of a wrinkling is called Joffrey sign. Then lid lag is called Congreve sign. Am I right?
Yeah.
I may not be very good in all these signs.
Have an obsession on asking this question.
I will normally don't expect the students because but anyway. So remember, lid retraction is the commonest. Exophthalmos is the second commonest. Then you can have other manifestations like, as you said, chemosis, dry eyes due to exposure keratitis. Then you can have your extraocular muscle involvement. Rarely you will have optic nerve involvement. Prints ideally should be treated by an ophthalmologist. Principles of treatment for exposure keratitis, you will want to put some lubricants, methyl cellulose eye drops, number 1. You can have the night mask, or you can have in the day, you can have sunglasses because of exposure keratitis. Treatment usually is steroids, initially oral steroids, then IV steroids. IV steroids, I think the commonly preferred one is methylprednisone. Nowadays, you have certain drugs which they may not ask you in the exam. These are recent advances. I think Dr. Urvi will be knowing more. Rituximab has been tried. I think teprotumab has been tried.
Suppressive agent, sir.
Yes.
Thioprim also been tried.
Yes, and our favorite COVID drug, tocilizumab, has been tried. These are all tried but not used extensively. This is medical. Then, in spite of all that, there's a rapid deterioration of vision. You should make the ophthalmologist either emergency orbital decompression or orbital irradiation. This is all I will know. Maybe my medical counterpart or ophthalmologist may throw more light.
Yes, sir. Dr. Ram, you are saying something, sir?
Yeah, I think, sir, as Professor Vittal has said, these are the things that we as surgeons need to know. Particularly, there is a mnemonic called no specs, which is very commonly said during an examination to know about the gradation of the eye sign. But it is good that to involve when there is an edema of the conjunctiva or the patient has a vision problem, to involve the ophthalmologist early into the picture, and so that the patient does not lose his vision. So these are the only things that we as surgeons need to know. And then a CT of the orbit is usually the investigation that is done to see the retroorbital inflammation, etc. With this, I think that we have had an extensive discussion.
Yeah,
today.
I think, yeah. Urvi,
Just to add one more, I forgot.
Yes, sir.
No specs is one classification. Nowadays, they use what is called clinical activity score. It is there. You don't need to memorize. It is between 1 to 7, just to know whether you have got active eye signs. It's nowadays called TED, thyroid eye disease. There is a score called clinical activity score. There are 7 points. More than 3 means he's got active eye disease. This assesses only activity. But if you want to know severity, then you will have to do other tests to see whether chemosis is there, whether he's got diplopia, strabismus, whether he's got strabismus and other things. Madam Dr. Urvi?
Ma'am, any inputs on your side, please?
Yes, sir. I want to also discuss surgery in a thyrotoxic patient other than thyroidectomy.
Please continue, ma'am.
Depression, sir, remains the same, and you have to continue your anti-thyroid drug. You have to give it before even surgery with sips of water, and after surgery you have to continue with this. And in case of thyrotoxicosis, if it is in an emergency surgery, then you have to be prepared with thyroid storm. Anesthetic also should be prepared in such a way that patient is having uncontrolled thyrotoxicosis. Otherwise, beta blocker and all remains the same.
Okay.
Anything else want to add in this?
No, I think sir has already said. So, okay, sir, Vittal sir, we'll call it a day then. I am really grateful to you, sir, and Dr. Ramon sir for joining us today, giving us specifically this particular day and time so that you can remain available on the platform. Thank you, everyone. Thank you, sir.
Thank you, sir.
Thank you. Hardik, you passed
Thank
the
you, sir.
exam with flying colors.
Yeah.
Right, sir.
All the students.
It was an excellent discussion and your inputs are
Really
very
enjoyed.
Yeah,
Thank
we
you,
enjoyed
madam.
it.
Sir, even I am taking notes. Even I am taking notes, sir.
Good.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, sir.
Okay. Thank you, everyone.